Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 20. We're going to talk about Mycobacterium tuberculosis, the causative agent of tuberculosis. Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 20, Mycobacteria and Mycoplasma. Mycobacteria have three distinct species which are medically important, including Mycobacteria tuberculosis, M. leprae, and M. avium. All three are obligate aerobes. These are acid-fast rods. They're non-motile and they do not form spores. Mycobacteria have unique cell walls that include mycolic acids. These have the longest chain length, they're strongly acid-fast, they're resistant to detergents, and they're resistant to most common antibiotics. So what you don't see is a huge peptidoglycan layer like we saw in the bacteria. You do have cholesterols, you have polypeptides, lipids, and then you have a cytoplasmic membrane. Mycobacterium tuberculosis is a frequent cause of pneumonia and can also cause extrapulmonary disease. It's a chronic disease that has a high disease burden in the third world countries. In addition to extrapulmonary disease, you can find it in the spine, which is called Pott's disease. In the brain, it can cause tuberculomas or meningitis. You can get a sterile pyuria from bladder infection. If it's disseminated throughout the whole body, we call that miliary tuberculosis. It can affect the heart and form a pericarditis, and almost any tissue in the body it can affect. It's a major cause of human disease. It can affect healthy people, and it has a high incidence in AIDS. This figure shows the clinical scenario with tuberculosis. What happens is you get transmission. In this figure, the mom has a hacking cough, and she spreads the tuberculosis in her respiratory droplets to the child. Within 6 to 8 weeks, the child is going to have a positive PPD test. The bacteria sets up an infection in the lung because it's a facultative aerobic organism, and you've got spread throughout the whole body. Fortunately, the body does a good response and you get healing within 6 months, and you form a scar there in that lower lobe. You can then go on to latent tuberculosis where you're PPD positive, and after years you get progression and you have reactivation tuberculosis in the apices of the lung, and it can spread any place. Also, you could have progression within 2 years, and that's 5% of people. And some people with HIV, 10% of people, can get progression to miliary tuberculosis because they're sick and they have a compromised immune system. Often, with HIV patients, you'll get active disease within 1 year of exposure. Transmission depends on person-to-person spread of airborne respiratory droplets. The pathogenesis often initially takes place in the lung with primary tuberculosis. It's distributed within the macrophages. It's a facultative intracellular pathogen. So as it gets eaten up by the macrophage, it inhibits the phagosome-lysosome fusion, and it resists lysosomal enzymes. In this figure, you can see that the body is trying to mount a cellular immune response against the infected macrophage. These little red squiggles indicate mycobacteria. They're living inside the macrophage. What happens is the body's immune response causes a lot of problems as more T cells go and try to kill the infected macrophages. That's what's called a granuloma. You have these giant body macrophages, multinucleated giant cells, and epithelioid cells, all of them with active TB inside them. Minor pathogenesis factors include mycobactin, which is a siderophore, which helps steal iron from the body, and cord factor, which damages mitochondria and inhibits the macrophage from killing the bacteria. Cell-mediated immunity is important for tuberculosis. And what you get is the bacteria initially infiltrate and infect the macrophages. The lymphocytes get activated. You form a granuloma, which is the GON complex, and also you can find tubercles in other parts of the body. Lab diagnosis of tuberculosis depends on acid-fast bacilli in the sputum. As people have a cough, they're coughing up the bacteria, you can grow it. You have to culture it on the Lowenstein-Jensen media, and it takes a long time, like several weeks to grow. You'll find non-pigmented colonies that produce niacin, and that helps differentiate Mycobacterium tuberculosis from other mycobacteria. You can get adenosine deaminase production. You can assay that in pleural fluid, in the ascites fluid, in CSF, or in sputum. Fortunately, we have a rapid PCR diagnosis, which allows us to get it much sooner than the weeks that it takes to grow. Clinical diagnosis often depends on skin testing with the Mantoux test. This is a delayed hypersensitivity reaction to the purified protein derivative of tuberculin. This figure shows introduction of the TB needle into the intradermal region where you have a small amount of tuberculin there. The body recognizes tuberculin if it's been exposed to tuberculosis and mounts a granulomatous response there. So you'll get induration and swelling, and you can mark it later with a pen to decide how big it is. The size of the area of induration gives you the clinical diagnosis, and positive results are dependent on 3 different sizes, depending on your risk factors for tuberculosis. If you have AIDS, or are immunosuppressed, or have had recent contacts with somebody with primary TB, a small skin test of 5 millimeters is large enough for you to have a positive skin test. The reason we have this is because you don't have much time to develop an immune response, or if you have AIDS, you don't have much of an immune response, and so anything counts. Less than 5 millimeters gets a positive test for these people. For people with increased risk, people who are immigrants, people who are healthcare workers who have been exposed but have a normal immune system, you need to get 10 millimeters of induration or more. Okay? People with no known risk factors who are not at high risk for TB need to have 15 millimeters of induration. This indicates exposure to the organism, but it does not necessarily indicate active disease. You'll then get a chest x-ray to show if there's an infection that you need to treat. Treatment for tuberculosis is extensive. It includes a long time period with multiple drugs. The organism is a slowly growing beast, and it's dormant most of the time. In addition, it has multiple resistance mechanisms for antibiotics. So the duration of your treatment depends on the level of INH resistance in the community, and you're going to treat it with multiple agents. To help you remember, there's an acronym of RIPES, R-I-P-E-S, which stands for rifampin, isoniazid, pyrazinamide, ethambutol, and streptomycin. If you have a positive test, you're going to get isoniazid for at least 9 months. And if you have active disease, you need isoniazid plus rifampin plus pyrazinamide for 2 months. Then you get isoniazid and rifampin for 4 months. We use combination drugs to limit the amount of multi-drug resistant Mycobacterium tuberculosis there is. If we have multiply resistant Mycobacterium tuberculosis, we have something that doesn't grow very quickly and is hard to treat in the first place, and now it's going to grow rampantly because it's resistant to all our drugs. Vaccination for tuberculosis has been tried, and it's frequently done in the third world or developing countries. It's a BCG vaccine, which is an attenuated strain of Mycobacterium bovis. It is effective at preventing miliary or disseminated tuberculosis in children that live in countries with high incidence rates, but it's not helpful in preventing pulmonary disease. We don't do the BCG vaccine in the United States because the incidence of miliary tuberculosis is low, and immunization interferes with diagnosis because somebody who's had the BCG vaccine is going to have a positive skin test, which kind of muddies the waters. Let's do a few questions. During routine PPD testing, you encounter the following people with the indicated responses. Which individual should receive a chest x-ray and will likely be started on standard multi-drug therapy? This question utilizes our ability to figure out which people are at high, medium, or low risk of developing tuberculosis and what size skin test they have which is interpreted as positive. So A, a 5-year-old child who has just returned from Mexico with 8 millimeters of duration. So we have somebody who is young but otherwise healthy, and they've been to Mexico without any real contacts, and she has 8 millimeters of duration. So this would be a medium risk. They need to get 10 millimeters of induration, and she does not reach that. B, an HIV positive individual with a normal CD4 count and 6 millimeters of induration. So even though they have a normal CD4 count, they're HIV positive, which puts them at high risk, and since they have more than 5 millimeters of induration, this is the person who I'd give a chest x-ray to. An IV drug user with 9 millimeters of induration. IV drug users are at greater risk, but they need to get 10 millimeters because they should have an intact immune system. Healthcare workers with cough and 9 millimeters of induration. Well, you can have a cough from a lot of things as a healthcare worker, and you need to have 10 millimeters of induration to be positive. A renal transplant patient with 4 millimeters. Renal transplant patients are often immunosuppressed, and so they would need 5 millimeters only to have a positive test. Fortunately, they only have 4. So the answer is B, HIV positive with 6 millimeters of induration. Next question. A 53-year-old heart transplant patient from Ecuador presents to you with complaints of dysuria and hematuria. Urinalysis is positive for white blood cells and red blood cells, but negative for casts, protein, or nitrite, nor are any bacteria visualized on gram stain. He denies fever, cough, or recent weight changes. A PPD reads as 6 millimeters of induration. The most likely explanation for this patient's urinary symptom is infection with. So we have an immunocompromised patient who's a heart transplant patient. They're from an endemic area like Ecuador, and they have dysuria. It's a tricky question because we don't frequently associate mycobacteria with a urinary tract infection, but we don't have any of the other signs of a bacterial urinary tract infection, such as bacteria in the urine, nitrites, casts, or protein. And so the most likely cause of this person's urinary symptoms is Mycobacterium tuberculosis. Staph saprophyticus is not a common cause of UTIs in heart transplant patients. Pseudomonas aeruginosa could do this, but is not usually associated with UTIs. Neisseria gonorrhea is not going to be normally without protein or casts or white blood cells. And then E. coli can cause a UTI, but you're going to see bacteria in the urine. Next question. A 29-year-old recent immigrant from India presents with a 2-month history of fever, night sweats, weight loss, malaise, and now hemoptysis. Chest x-ray shows cavitary lesions in the right upper lobe. You start her on rifampin, isoniazid, pyrazinamide, multi-drug therapy, and inform her that you're going to need to monitor her monthly for. So this is something we didn't necessarily talk about, but each of the medications we talk about have different side effects. We talked about this in the medication and antibiotic section earlier in microbiology. We know that ethambutol can cause blurry vision, and we'll need to screen for that. But the other medicines, the rifampin, isoniazid, and pyrazinamide, are all hepatotoxic, and so you'll need to monitor serum transaminase levels frequently. Pulmonary function tests are important, but not necessarily because of the medication, just to see how the disease process is going. Vision screening is important for ethambutol. Hemoglobin levels are important for anemia, which are not really associated with these medicines. Urinalysis doesn't really apply here. To summarize Module 20, you'll have to be familiar with many aspects of tuberculosis, from its spread of aerosols to its life cycle from primary and reactivation infections. You'll also be familiar with the protein manifestations of secondary tuberculosis. You need to be familiar with how mycobacteria are different than other bacteria and different than us. And you have to know the PPD stages. People who are at different risk factors have different levels for a positive test. People who've been vaccinated with the BCG vaccine have a positive PPD, but that doesn't mean they have the active disease. And it only prevents miliary disease, so we don't give it in this country. You have to know the different bacterial treatments for tuberculosis and the side effects of some of those medications. In Module 21, we're going to go with the other mycobacterial species and talk about leprosy.